2004. Mr. G, a 43-year-old gentleman, farmer by occupation from Andhra Pradesh, presented with complaints of alleged history of scorpion sting in the right foot at 11 a.m. on the 9th of November this year, and followed by that he had weakness of right upper and lower limb since 11 p.m. on the same day. So the history of presenting illness, he was apparently well until 9th of November when he sustained a red scorpion sting when he was working in the field at 11 a.m. He immediately went to a local hospital and was referred to a higher center. In the hospital, he developed symptoms like palpitations, chest tightness, profuse sweating, and had one episode of vomiting. He was treated with prazosin, antibiotics, and steroids, considering it an autonomic storm. And around 11 p.m. on the same day, he developed sudden onset weakness of the right upper and lower limb and had difficulty in articulating but was able to comprehend. There's no history of sensory deficits, no associated headaches, seizures, loss of consciousness, diplopia, no neck pain. He was brought to CMC for further management. Past history-wise is nil comorbid, personal history-wise an occasional ethanol consumer. On examination, vital signs were normal. There was no carotid bruit, no pallor, icterus cyanosis, clubbing, lymphadenopathy, or pedal edema. Cardiovascular, respiratory, and per abdomen examination findings were normal. CNS examination findings, GCS 15/15, he was conscious, cooperative, and oriented. On cranial nerve examination, there was deviation of angle of mouth to the right, and he had a gag which was weak. Motor system, other cranial nerve examination findings were normal. Motor system examination, tone was normal in all 4 limbs. The right upper limb, proximal and distal muscles were, the power was 3/5. Hand grip was weak on the right side. Lower limb, proximal and distal group of muscles, the power was 4/5. The right side power in the upper and lower limb, proximal and distal group of muscles were normal. Deep tendon reflexes were 2+ in all 4 limbs. The right plantar was mute. Sensory system was intact. Cerebellar signs were normal. No meningeal signs. Skull and spine was normal. So this is a syndrome of right hemiplegia, 12 hours following a red scorpion sting. And he had features of autonomic storm that was present in the outside hospital. So basic investigation showed the leukocytosis with neutrophil predominance. Creatinine was elevated 1.5. Urea was 92. The drop enzymes were 335, which was in the declining trend, to 186.7. CKMB was also in the declining trend, 11.7 to 3.4. ECG showed a regular sinus rhythm. There was with a heart rate of around 75. The QTC was prolonged, and there were no other characteristic features of myocarditis in the ECG. The echo was done, which showed a normal LV systolic function with good contractility. CT brain on arrival showed a large left MCA infarct with a mass effect, with effacement of left sulcal spaces and left lateral ventricle. There was a midline shift of 4 mm to the right. When he came to the ward, we repeated again. The CT plain brain showed further worsening of the midline shift to 7 mm to the right. Neurosurgery consult was sought. Left frontotemporoparital craniectomy was done, and he was shifted to the ICU. He was sedated and ventilated for 48 hours post a decompression craniectomy, and he was extubated yesterday, and he is monitored in ICU currently. So I would like to highlight my learning points in the next 2 to 3 slides from this patient. So the incidence of cerebrovascular accident post scorpion envenomation. Around 53% of the people develop hemiparesis following a scorpion sting, and imaging details typically present in CT in 81% and MRI only in 18%. And hemorrhagic strokes are common in 41%, and infarcts are common in 53%. The most common type of infarct is a single infarct, unilateral, single infarct 53%, unilateral is present in 70.5%. And hemorrhages, again, single hemorrhages, unilateral hemorrhages are common. And the outcome in out of the 17 people that were included in the studies, 13 people were alive, 20, which is around 76% in the infarct group. And out of the 13 people in the hemorrhage group, 61% people were alive. And among the sites involved, the most common site involved in the hemorrhagic group people was the capsuloganglionic region, that is 30%, and followed by putamen, followed by frontal and parieto-occipital hemorrhages. In the infarct group, the most common site is the parieto-occipital, followed by cerebellar, then followed by other regions like capsuloganglionic, frontal, thalamus, and midbrain. So there are various phenomenon mechanisms postulated as to how the scorpion sting, the scorpion envenomation causes infarcts or hemorrhages. These were the 6 pathophysiologic mechanisms that I could find from the case reports that were published in various journals. First one is an autonomic storm, which is most commonly seen in the Bavaskar grade 2, which causes a sudden surge in blood pressure, causing rupture of perforators. The second phenomenon is myocarditis-induced cardioembolic stroke. Third phenomenon is venom-induced DIC, causing increased platelet aggregation. And the fourth phenomenon is venom-induced vasculitis caused by endothelial damage. Then hypotension-induced watershed infarct, which is again more commonly seen in the 4 stages of Bavaskar grading. And catecholamine-induced increased endothelium resulting in vasoconstriction is another mechanism. So this catecholamine excess is caused because the scorpion sting venom causes activation of the voltage-dependent sodium channels, along with which there is a calcium entry into the cells, and they go and the calcium enters to block the potassium channels, leading to relative hyperkalemia, and that leads to a catecholamine excess. So these were the few case reports that were published related to this topic, as CVA leading CVA following scorpion envenomation. So the learning points from this patient is acute infarct is a rare complication of scorpion envenomation and the various pathophysiological mechanisms involved. Thank you.
This patient blood pressure at admission was it high or?
No, sir.
No.
He had autonomic storm elsewhere.
Elsewhere, and he was.
What was the pressure at that time? Do we have the data?
There was no document.
Okay.
What was the indication for antibiotics and steroids? That is something we gave, or
that was given in the outside hospital.
What did we do?
We monitored. He had high spikes in the ICU, so we started him on meropenem in the ICU. Blood cultures are awaited.
Oh, he's still in the.
He's still in the ICU.
And steroids, we are not.
We are not giving steroids.
And maybe I read it wrong, but did you mention that it was special education to the right side? Did you mean that?
Yeah.
Any more questions?
Steroids, would that have precipitated the stroke? As you mentioned, already there is a procoagulant state. So steroid is only adding on to the procoagulant state. Maybe that should have precipitated. How much was given?
So there was no documentation.
We don't have an MRI on this patient.
We don't have an MRI.
Okay, that's another thing, just to assess the vessel status, especially somebody is going for a major surgery, maybe just a stroke protocol to have an idea would be helpful. So,
Most of the studies, you have seen the age group in which most of them present with strokes.
Young stroke, I found some two studies with young patients, and others were more than 50.
So then they already have got some underlying, say, atherosclerosis on which this would have precipitated could be a possibility. That's one thing, because in a young patient with a very normal vessels and all, for them to precipitate can happen, but it would be less likely than people who are more elderly with some risk factors for strokes or atherosclerosis. Something to be looked at, something that you can look into all the studies and see is consistently stroke seen among those age groups of people with some comorbidities. Whether that can explain whether this is precipitated and not just because of scorpion bite that they want.
thank you, sir. Now I call upon the last presenter, Dr. Mithun.